hospital pharmacy, you are ensuring that the right route, right dose, those odds are justified. Moreover, pharmacy deals with the patient safety, like decreasing the areas. There are multiple other steps like health promotion, education, disease preventions. So patient counseling as well. And one of the most important is about the collaboration with the healthcare teams, like doctors, nurses, and other healthcare staff, for example, microbiologists as well, and where you are going to implement different treatment plans, etc. When we talk about the specific roles of the clinical pharmacist, that everybody wants to be a clinical pharmacist, but to become a clinical pharmacist, the roles being a clinical pharmacist are more direct patient care roles. For example, when I talk about, say, about direct patient care, then it means that uh, you would be involved in a decision-making process. You would be at the bedside. And when you would be at the bedside, uh, decisions would be taken there and you would be asked, for example, if this patient needs this medication or not. So being a clinical pharmacist, direct patient care is there where you perform different kind of intervention, therapeutic drug monitoring, patient assessments. You will apply your knowledge and you will recommend different kind of drugs, and those would be the evidence-based medications. And being a clinical pharmacist, if you look at the American College of Clinical Pharmacists protocol, you would find around about 120 stars. That is a 6-page document that you can find it very easily. So there are more than 120 tasks that you can do there. So being a clinical pharmacist, that he or she is more involved in direct patient care, where decision is made, and while as a hospital pharmacist or as a community pharmacist, you have to follow the instruction. The orders are there, then you have to intervene or so.
सर ये बात हमने क्या लाइक हम जब जाते हैं वार्ड्स में पेशेंट को देखते हैं आईसीयूज में देखते हैं कि ड्रग की नीड है या नहीं है, या इंटरेक्शंस को देखते हैं, मेडिकेशन सेफ्टी के पॉइंट ऑफ व्यू से देखते हैं। लेकिन अगर अगर हम ये बात करें तो क्या हमारे लिए जो हमने रेजिडेंसी के पॉइंट ऑफ व्यू से, या एक स्टूडेंट है वो, क्या हमें जो हमने 5 साल डिग्री में पढ़ा क्या वो एनफ नहीं होता? व्हाई वी नीड टू लाइक वर्कशॉप्स अटेंड करना? क्योंकि अगर जैसे आप वार्ड्स में जाते हो वो नॉलेज जो आपने बुक में पढ़ा है और आपका प्रैक्टिकल बेस टोटली डिफरेंट है। सो उस चीज को कैसे सीखा जा सकता है, उसकी नीड क्या है और हम उस पर कैसे काम कर सकते हैं?
दिस इज अ वंडरफुल क्वेश्चन, जो कि हर कोई बंदा शायद यही सोचता है कि आई हैव डन अ 5 years डिग्री प्रोग्राम नाउ, आई वुड बी अ फार्मासिस्ट एंड आई एम अ कंप्लीट फार्मासिस्ट। सो जहाँ तक बात होती है सर्टिफिकेशंस की, नॉलेज की, तो एक बात याद रखिएगा कि नॉलेज जो है वो कभी भी जो है वो खत्म नहीं होता। यू शुड ऑलवेज बी इन्वॉल्व इन लर्निंग। हमेशा सीखते रहना चाहिए, नई से नई चीज को अडॉप्ट करना चाहिए। 5 साल की डिग्री आप करते हैं, यस, दैट्स अ वंडरफुल डिग्री, वी ऑल्सो डिड दैट एंड यू आर ऑल्सो डूइंग दैट। लेकिन उसमें एक जो इशू है वो ये है कि दैट्स अ थियोरेटिकल पार्ट, वो आपका एक नॉलेज है, ठीक है। लेकिन उस नॉलेज को इम्प्लीमेंट करना, उस नॉलेज को सही तरीके से, यू नो दैट फॉर एग्जांपल के एस इनहिबिटर्स दैट आर कॉजिंग, उनका एक साइड इफेक्ट है हाइपरकैलेमिया, देन यू मस्ट नो के उसमें फिर आपने उस चीज को इम्प्लीमेंट करना है, रियल प्रैक्टिस में करना है। देन उसमें डिफरेंट तरह के केस सिनेरियोज होते हैं, एंड विद केस सिनेरियोज आप उस चीज को लर्न करते हो। एंड जो आपका कोर्स मटेरियल होता है दैट इज द बेस लाइन। और एक चीज जिसको मैं शदीद इख्तलाफ करता हूँ, ये कहते हैं कि जी कोर्स की जो बुक्स हैं और जो प्रैक्टिस है वो टोटली डिफरेंट। आई नो दिस इज रॉन्ग, दिस इज कंप्लीटली रॉन्ग। ऐसा बिल्कुल भी नहीं है, ठीक है। जो कोर्स की बुक है दैट इज एक्चुअली द बेस लाइन, वो एक फाउंडेशन है। जब आपकी फाउंडेशन स्ट्रांग होगी तब आप उस नॉलेज को इम्प्लीमेंट कर सकोगे। सो 5 साल की डिग्री आपको एक नॉलेज, एक बेस लाइन प्रोवाइड करती है। उसके अलावा जो फार्मेसी फील्ड है वो बहुत ही वास्ट है, उसमें डिफरेंट तरह की मेडिकेशन सेफ्टी शायद वो हम अपने करिकुलम में कवर नहीं करते, इम्प्लीमेंटेशन फेज वहाँ पे हम कवर नहीं करते। सो इन दैट केस सर्टिफिकेशन एंड कंटिन्यूस प्रोफेशनल डेवलपमेंट, जिसमें लर्निंग के लिए कुछ कोर्सेज करने होते हैं, दैट इज वेरी इंपॉर्टेंट एंड यू हैव टू डू दैट। अगर आप वो नहीं करोगे देन यू वुड बी एन आउटडेटेड फार्मासिस्ट, और जब एक आउटडेटेड फार्मासिस्ट जाता है तो एक गुड फार्मासिस्ट वही होता है, बेशक आप किसी भी जगह पे होते हो, जब आप एक नॉलेज के साथ एक एविडेंस बेस्ड मेडिसिन के हवाले से बात करो, क्या ये रेफरेंस है, उसमें ये चीज बताई गई है। जब आप इस तरीके से बात करते हो तो तब वो चीज वैल्यू होती है। लेकिन अगर आप यही कहते हो कि जी, फॉर एग्जांपल मैं ये एक सिंपल एग्जांपल क्विकली देता हूँ कि 2019-20 में कोविड आया, ठीक है। 2020 के शुरू में जो कोविड की जो ड्रग्स थी या जो चीजें हम कर रहे थे, अगर क्या आज 2024 में वही चला सकते? नहीं चला सकते, क्योंकि थिंग्स हैव बीन इवॉल्व। तो इसी तरह गाइडलाइंस जो होती हैं वो कंटिन्यूसली चेंज हो रही होती हैं, आपको उसी तरीके से इसको देखना होता है। Okay, there is a comment as well. Thank you, Mr. Sandeep, that I have to communicate in English. No, I will communicate in English.
So there is thing like आपने ये तो you have explained it very well, like why there is a need to learn new things after your degree. But what are the possible ways or means to learn these things? Like residency is an option, internships are option. How options we can attain or avail to enhance our knowledge, so we can better do a pharmacy workup.
Okay. For enhancement of knowledge, I guess you are going to ask this question: how we can enhance our knowledge. For enhancement of knowledge, the first thing is your will. If you want to enhance your knowledge, then you have to read. You have to read different guidelines, and you have to go for different study materials, for example, publication, resources, articles, etc. And when there is a thing in you that you want to learn, there would be different kind of queries you will come across, and then you will search and you will find different kind of answers, and then you will analyze it. And what are the resources available? If you talk about the professional degrees or courses, then if you talk about the degrees, MPhil degrees is very common among the pharmacists, but the courses like board certifications or international certification from different international universities like Harvard, SIDP, uh, those are there. ASHP also, American Society of Health System Pharmacists, also offer different kind of certifications. So you should go for those certifications to learn. And I think that those platforms are very good. And one thing you must consider while going for those certificates or while paying for those certificates, that always have those certificates that are relevant to you. For example, if you are working in a hospital and you are going to have a certificate about the pharmaceutics or pharmacognosy, that might not be so helpful for you, and that might not be adding so much value in your future career. So there are different type of, the answer simply is that there are different type of platforms online, for example, ASHP, board certifications, SIDP, Harvard University, a different type of university provides online certifications. But the most important is you yourself, that who will exert him or herself to gain knowledge.
Thank you. Thank you, sir. I just want to add something, like जो हम सारे बात कर रहे हैं, it's only not related to clinical pharmacy. Being in any place, आप community में हो, industry में हो, या किसी भी branch में काम करें, you can gain knowledge of pharmacy work is not work is only not related to clinical pharmacy. So it's a vast option. Thank you, sir.
Right. Talking about the PWDT, what factors should be considered during the selection of a drug recommendations? And does considering lab values and diagnostic tests is important? If yes, how?
Oh, that's a very long debate. For PWDT stands for Pharmacist Workup for Drug Therapy. Pharmacist workup for drug therapy is just like a homework before preparedness before going to any round or any kind of intervention. So PWDT is basically a tool, or you can say a thought process. If you search over the Google, then you will come out that it's a tool that is used by a pharmacist to make interventions. And intervention is actually something, any kind of step that you are taking to optimize the medications therapy. And optimizations mean, for example, there is a side effect, you are reducing those side effects or something like that. So you are making intervention, and for that information, there must be some kind of workup, and that workup is known as PWDT, that is Pharmacist Workup for Drug Therapy. And there are multiple steps of conducting pharmacy workup of drug therapy. If PWDT is not well enough, and if you haven't prepared your own quite well. Of if you're not aware about the patient, then you can't make quality interventions. So PWDT is the most important step for making any kind of interventions. So PWDT actually it's a thought process, and it is not a form. I told you that if you Google it, you will find a form, PWDT form, that contains a list of uh, fields that you have to fill before making any intervention. Yes, those are important, but not every field is important. Actually, it is a thought process. The thought process that is in your mind. For example, if I say this is a drug that has to be dispensed. Okay, for example, if patients come to your pharmacy for asking a drug for the constipation, and you see that there is a medication, morphine or opioids, in that you must think in your mind that the tools or the process should be like, you have to evaluate what could be the reason of the constipation, whether there is any medication or there is any medication history. So for that simple thing, you would go there and you would find that, okay, it's an opiate and that could be a side effect to this patient. So this is a thought process which enables you to make a very good interventions. So you asked that what are the different steps we have to conduct. And for the conduction of the PWDT is a very long step. I will try to make it short for you people, like how you're going to make a good intervention, or how you are going to optimize the medication therapy. So first of all, you have to establish a comprehensive patient specific database. When I talk about the patient specific database, then that includes all the information about the patient. All information about the patient, its height, weight, gender, ethnicity, that is important. Its social history as well. And there are so many things like patient database include weight, etc. You have to add those things because these are the things that will help you to make future recommendation. Then you have to identify the drug-related problems. Drug-related problems or the patient-specific problems. For example, drug-related problems could be like there is a less dose, there is a higher dose, or there's a patient-specific problem that patient is a fast metabolizer, or like that thing that patient has amputation or CKD, etc. There are multiple things. Then you have to identify patient-specific and drug-related problems, and then you have to describe your therapeutic outcomes, what you want to do. For example, if you're going for example, you have to design your desired therapeutic outcomes. Sorry, I'm looking at the questions as well. So I think so someone is taking those questions and will put it back to me after some time. So, and there's some disruptions. So you have to think that what would be my desired therapeutic outcome, whether it is an acute condition or it's a chronic condition. For example, if it's a chronic condition, for example, diabetes, then there would be a desired therapeutic outcome like we want to have a target of HbA1c less than 7, or we want to have a blood pressure less than 140/90. So these are the desired therapeutic outcomes, and for that you have to list all the alternatives. Then when you decide that what would be the my desired therapeutic outcome, then you will list all the therapeutic alternatives that might produce that desired outcomes. There could be so many drugs that could be helpful for you in reducing the HbA1c, like blood sugars. It would be bigonides, sulfonylureas, DPP4 inhibitors, SGLT2 inhibitors, so many things. But which one you would choose? So first of all, you will select all those. And then after listing all those alternatives, you will select the drug recommendation that most likely will result the desired outcome. And when you have list of all those things, it is like when you are going to some place, there would be multiple ways of going to a place, but you will choose the one that is most comfortable and where your time would be saved and you could easily reach there. So this is like listing all those, and then you will select the one that is the most best. For example, if I'm talking about
नमाज पढ़ ले फिर एक जना किचन में जाए ना मेरी वो चल रही है
sulfonylureas, etc. So, for example, if there is a patient on sulfonylureas and he has CKD,
नहीं
etc. The
अकेला
sulfonylureas, there should be a decrease in the dose as well. So for DPP-4 inhibitors, you have to see that whether CHF is there or not, or if hypoglycemia is the concern. So these are the different things you have to list, and then you have to select which is the best option. And after that, what you will do that you will establish a therapeutic drug monitoring plan that documents that desired effects occur and undesired effects are minimized. So this is actually short. Uh, if I review it, like, first of all, you have to establish a comprehensive patient-specific database. Other one is that you have identify patient-specific drug-related problems. What are drug-related problems and what you want to achieve? That is the desired therapeutic outcomes. Then you list what are the alternatives you have, and then you select the best alternatives. The best alternative shouldn't have any contraindication or the best options you have. And then you establish a therapeutic plan that how I will continue this. So this is all about PWDT short steps. I tried to conclude it. The multiple questions, should I take it myself, or you are going to ask those, or it would be at later stage?
First, we are going to ask the questions when you're there. So after we've discussed the key components and the comprehensive steps of PWDT, how can you explain the patient-specific database that is used in the pharmacist workup, and how can we connect these two things?
Yes, I briefly explained in PWDT, and this is a wonderful question. Patient demographic is the most important thing. Whenever you're going to make an intervention, for example, if you're not about the patient demographics, if you have just a piece of paper full of medications, you would not be able to make any kind of intervention. Whether you must be aware that whether it is for whether it is a young patient or adult patient. So this is very important thing. For example, for a young patient, what you have to consider, for example, ceftriaxone. There's an order of ceftriaxone. You are receiving a medication like ceftriaxone 200 mg OD. That's an order for you. But you can't make any intervention unless and until you know about it. You come to know that the patient is just 10 days old. So in neonates, you're not going to dispense ceftriaxone. So that's a contraindication. So in that case, patient demographic is the key. So patient demographics should be there, and you should take into account, like name of the patient, age of the patient. Age of the patient, for example, as one case is the neonates, the other case is the geriatrics. For example, there are multiple drugs like nitrofurantoin. According to the BS criteria that discuss about the drugs used in the geriatric patient, that will say that, okay, this drug cannot be used in the geriatric patients. So age is there. Gender is there. For example, if I have a age of 25 and gender of a female, and I'm going to dispense any kind of drug, for example, that is a teratogenic, and for example, valproic acid. So valproic acid has a warning that it's a teratogenic, and it should be considered. It should be asked for the women who are pregnant or who are going to be conceived. So these are the parameters that is most important. Weight is the most important thing that we usually come across, that a different type of waste, different type of weights have been used. Sometimes we are going to use ideal body weight, sometimes adjusted body weight. So weight is there, height is there, BSA. So body surface area, you might come to know different type of medications have body surface area dosing, for example, in peds or some chemotherapeutics. So that is important. This is just about the patient demographics. Moreover, patient history. Patient history is important. For example, there are two types of history, that is medical history and medication history. In medical history, you will see that what are the current and past medical condition he or she has, or what is there any surgical intervention, or their family history of diseases, or any relevant social history, for example, smoking. You must know that we don't consider that smoking has any kind of interaction, but smoking have interaction, that is CYP1A2 inducer, and it has an interaction with, I guess, amlodipine or antipsychotic drugs. So it is CYP1A2 inducer, so it is interacting. It is also interacting, for example, for the patients who are on contraceptives, for example, on estrogen. So these things we have to consider. Alcohol use, that is not so much common in our society, but we have to ask it, because if a patient is coming to you with some kind of encephalopathy or coma shock, and you must ask whether he or she is on alcohol use or not. Because if he's on alcohol use, then most probably he's a patient of chronic encephalopathy, whereas there is a deficiency of vitamin B1. So you have to give vitamin B1. So these things you have to ask. Medication history, I think so. I don't need to explain that thing, that medication history is very important, what kind of medication he is taking or she is taking. For example, I think so someone has started the whiteboard, please close it. Okay, thank you. So medication history is important in such a case. For example, if a patient is coming to your pharmacy and saying that he has hypokalemia, and upon review, you come to know that patient is taking insulin as well. So hypokalemia is a side effect of insulin for the time being. Or if a patient come to your pharmacy for hyperkalemia, and then you come to know that patient is taking potassium-sparing diuretics. So these are the things you have to consider. I think so. Your question also contain information about the laboratory values as well. So if I talk about
that question, sir.
Oh, sorry. So
Yes, sir.
I want to give that answer here. Actually, what I'm talking about here is just an overview. If we take those things into account, it would be a very huge discussions. And I would recommend you to please go for those things, because these are very critical steps. You must know how history taking is important, how laboratory and diagnostic data is important. For example, a laboratory is actually indicator of disease progression or etc. And we must know some baseline labs that are very important for us, specifically those drugs where there is a rule, or I can say there's a working process. Okay, we must always consider laboratory when a drug is changing the laboratory. When a drug is changing the laboratory, or laboratory is changing a drug. For example, drug is changing the laboratory. For example, if I'm saying that ACE inhibitors are causing hyperkalemia. ACE inhibitors cause hyperkalemia. So in that case, what you have to do, that you have to take potassium levels. So because drug is changing the laboratory. And the other case, the laboratory is changing the drug. For example, if a patient has a serum creatinine clearance of less than 15 ml per minute. So if you're going to SGLT2 inhibitor, and SGLT2 inhibitors are contraindicated for less than 30 or 50. Okay, in that case, what you have to do, that you are not going to give that medications. So in that case, laboratory is important. So always consider when laboratory is going to change the medication, or the medication is going to change the laboratory. So there are multiple kind of laboratories. Might be there is a lecture on YouTube. I think so. I have given a lecture on YouTube as well. That's all.
Now we know that we have to make certain decisions. हमें ये पता है कि डेमोग्राफिक्स है, वेट इतना होगा, क्रेटिनिन इतना होगा, ये हमें पता है. बट एक नया ग्रेजुएट आता है बिल्कुल फ्रेश, उसको ये रेफरेंसेस कहाँ से मिलेंगे, कैसे पता चलेगा उसको कि ये चीज एबनॉर्मल है, ये चीज नॉर्मल है, तो कैसे इस चीज को आइडेंटिफाई करें?
Okay, for a fresh graduate, how he would learn about these demographics and about the importance. The only thing is that your baseline knowledge should be strong enough. For example, you are going to read Lippincott, Katzen, or some pharmacy books are there. That category gives information about the age-related contraindications, disease-specific contraindications. If you're going to implement those, that's wonderful. Otherwise, there are different kind of resources. And in one of your podcasts I just have seen a couple of some time ago that your podcast about drug information resources.
Yes,
You have mentioned different type of drug information resources. If you could help them to find those drug information resources, and specifically those are free. For example, Medscape, that is free. Or if you Google it, you would find many, but please just don't Google it. Google is not a reference. The reference should be one that is authenticated and that has some kind of values. If you are good enough, that like that you can evaluate primary, secondary, tertiary resources. That's wonderful. Tertiary resources are very easy to use for you, and that is more reliable. Primary resources are something that is very uh, up to date, etc. But that is some tricky as well, because you must know whether this study is significant or not. So where you could find the different references, references are there, PharMentorZ is there. That are the references for you. You could email them, and they have to provide you. Yes, someone told that Micromedics.
Okay, sir,
So
now what
we
are
have,
the different
so we have
factors?
participant as well, who is helping me as well. Thank you so much.
You see, our audience is enlightened.
Thank you so much for helping me.
Yeah, our audience is enlightened. You can see that.
Thank you. Thank you.
Okay. Sir, now we've discussed medications, we've discussed demographics, lab values. Another point that I think should be talked about is compliance of medications. Should pharmacists also monitor this? And should they go for therapeutic drug monitoring as well? Does that come in pharmacist workup?
That's a wonderful question. What we want, that is the best patient outcomes, and best patient outcomes will not be achieved when patient is not compliant to the instructions. So medication compliance assessment, a pharmacy should be involved in it, because therapeutic efficacy is based upon the compliance. If a patient is not taking medication, then how you would ensure that his therapeutic goal, for example, achieving a blood pressure of 140/90, you could achieve that. So compliance is very important, and you have to ensure that patient is compliant. There are different type of strategies to evaluate the compliance, and compliance is actually could be monitored with the use of labs as well. For example, if a patient is taking any kind of medication, for example, warfarin with therapeutic drug monitoring. So a good question is there that TDM and its compliance both are relatable. So TDM, I will come into compliance as well later, but TDM is important because therapeutic drug monitoring, in therapeutic drug monitoring, what we do, that we are ensuring efficacy and safety. So TDM is important, and we have to conduct that. And we have to conduct for those drugs where there is a concern in pharmacokinetic parameters, pharmacokinetic parameters of the patient. We have a separate session. Okay. So in that case, TDM is very important. Pharmacists have to conduct. Pharmacists must know what kind of drugs are there and how TDM is to be performed. There are multiple drugs where TDM is performed, and I think so you have gone through it. TDM also helps to check the compliance. For example, patient is taking warfarin and his INR, which is normally 1. So, okay. So if you are giving a patient warfarin of 5 mg OD, and after some time he's coming back to your pharmacy and his INR is again 1.1. So in that case, there might be a question that whether he's taking that medications or not. So that it shows about the compliance. If patient is not taking the medications appropriately according to the adhered criteria, according to instructed methods, so you're not going to achieve those things. So it could be a joke, I guess. These residents have identified in our World Pharmacist Week that a patient complained that these medications are not up to the mark. This is a story kind thing. So patient complained that my patient is not getting well. These medications are not up to the mark. So upon inquiry, we came to know that patient is taking the inhalers capsules, that Rotahaler capsules are, and he's eating. The patient is eating. Actually, those are for the inhalation. So the patient is non-compliant. So in that case, how the effect would be produced? So if a drug that is not for the oral use, for example, insulins are not for the oral use, and you are taking it orally, so how the effects would be there? So compliance is important, and you have to assess the compliance. It could be like open-ended questions, like one-to-one discussion with it, um, uh, or it could be like medication refills. For example, if a patient is coming to your pharmacy and he's asking that please give me this medication, but not this medication. I have this medication. That indicates that he has taken all those drugs, but might not be those medications. Moreover, there are different type of adherence tools. For example, Moriski's medication adherence tools. You can use that as well. So moreover, different type of technologies. That's so many methods, and you must include compliance as well, because without compliance, if patient is not compliant, you are not going to make any intervention. And for compliant, one thing for the patient of Alzheimer or those with the memory problems, I would suggest, for example, if patient is taking a drug 3 times daily, and you have an option of a drug with a once time daily, so that is also making a decision for you that, okay, what kind of drug you are going to give this patient. Obviously, the drug with a once time daily or with a long acting action.
Well explained, sir. Sana wanted to ask a question.
Okay, sir, there's a question that we treat patient, not the labs. What's your stance on this?
Sorry, can you
Sana, we
repeat it,
didn't
please?
catch your question.
Sana, repeat your question. Neha,
We treat the patient, not the labs. What's your stance on this?
Treat the patient, not the labs. This is what you are going to ask. Okay.
I think
This
that's
is
what she
a very good point, that treat the patient, not the labs. Yes. Whenever you are going, for example, how to set the standards of the lab, how you can say that this is the normal value. For example, I told about that INR is 1, or you can say that, for example, BP of 120 by 80, blood pressure of 120 by 80 is the normal. Okay, so from where it comes? It comes from the normal patients. They might have taken 1,000 normal patients, normal people, and they monitored their blood pressure, and they found that 95% of those patients, people have a blood pressure around about 120 by 80. This means that there would be normal patients that have a blood pressure might be 100 by 60, might be 140 by 100. But 95% of those population must have a value between 120 by 80, that have this value range. For example, moreover, I can say, like, for potassium, the normal range is 3.5 to 5 MBQs. Okay, so 95% of the population have those at the normal healthy state have a value of between 3.5 to 5. But this does not mean a normal patient cannot have a value of 5.5 or 2.5. It could be, but those are the outliers. So in that case, for example, if a patient that might have a value of 5 potassium, that might be appropriate for him. He's not feeling any kind of difficulty. He's living healthy life from the day one, etc. So in that case, it is not necessary to treat the lab as well. For example, a patient has a valproic acid of 20. Okay, normal valproic acid levels are 50. Okay, in that case, we say that patient with the 50 to 100 have a good epilepsy control. 95% patient have a epilepsy control when they have a levels of 50 to 100. So if a patient have a levels of 20 and he's not in epileptic form, etc., so he's stable. So there is no need to increase the anti-epileptic drugs. For valproic acid, there is no need to increase that. Okay, I have to go to the 50s to treat that patient. No, in that case, treat the patient, not the lab. If patient is fine, that's fine. But yes, the standards are being made for the 95% of the population. Always treat the patient, not the lab, but labs are indicators.
That's great, sir. There is a question from my sir that if a pharmacist doesn't agree with the care plan of a physician, then how can a pharmacist can make an intervention? And what are the different ways a pharmacist can intervene with the best possible ways?
Oh, it's a good thing that in a society like Pakistan or might be internationally, we don't have experience of international, but there are some kind of intervention that are not accepted. Okay, we have a role that we should inform that, we should inform that this you have to do it. For example, if a patient is receiving a medication that could exacerbate the patient current scenario or current, for example, ACE inhibitors. Okay, ACE inhibitors are going to increase the potassium level for a patient, and you are telling the patient, doctor, that please don't prescribe this medication, that patient is hyperkalemic, and doctor is not going to listen to you. How you will do it? The best thing is your knowledge, and the other thing is your reference. Okay, the knowledge, if you have a knowledge, the baseline knowledge, there must be a sound stance what you are taking. If you are saying to a doctor, I don't see any reason that a doctor is not accepting your thing, tell them that, okay, sir, because this patient has this thing and this is the proof, this is the reference. This reference is telling that the drug you are going to dispense is way high or too low. In that case, go with the strong reference, tell them what is the reference. And yes, there would be chances that doctor might turn down that, no, I'm not going to accept this intervention. So don't worry about it, just log it into the system. And if you think that it is too much critical intervention that could result in the patient harm, please escalate that information to the seniors as well, that this is something that is going and that could be devastating for the patients. So if you are going to discuss it with some kind of references, surely the doctor will approve it.
All right, sir.
So you have mentioned clinical interventions and like verbally तो वो discussion हो रही होती है, तो आपने कहा कि log in करनी होती है वो चीज, तो documentation की क्या importance है when it comes to doing PWDT? किस
Okay.
हद तक documentation important है?
There's a question as well, I think so 2 to 3 times being asked that about the patient care plan as well and documentation. This is actually the same thing. Documentation, when nothing is documented, nothing is done. When you have not documented anything, you don't have any proof. For example, if a patient is having hypoglycemia, if we had a hypoglycemia and they are not giving the potassium, or they are giving very low dose potassium, and you are making any kind of intervention. If it's accepted, that's wonderful. If it's not accepted, but you have to document there. If you're documenting it, then it means you have a proof that it's been done. In case if there is any kind of issues, any kind of problem in the medical history, then pharmacist would be asked, and pharmacist is custodian of the medication. He would be asked, not the doctor would be asked that you entered the wrong dose, not nurse being asked that you administered the wrong dose. It's the pharmacist role that why you haven't intervened. So documentation is the most important step. So always document, and how to document, and what is the patient care plan. As I have told you, the patient care plan would be 2 types of care plan. For example, if it's the acute case, then that would be a resolution of the symptoms. For example, it's a pain. So in that case, the resolution of symptoms would be your plan. For chronic medications, there would be some kind of target you have to achieve, as I have told you, the HbA1c. So the plan should include subjective. There are 2 types of methods in which you write your plan. For example, either in the SOAP form, that's subjective, objective assessment and plan, or the form, FARM form, finding, assessment, resolution, and monitoring. Those are different type of plans. You have to use it because these are the plans. In that case, for example, subjective plan, in subjective things, you will see that what kind of patient demographics, etc. Objective, what are the exact values are there, and then assessment and plan. In assessment, you will say what kind of the drug related problems you identify, what are the problems are there, how you are going to achieve those things, and how much time you are going there. And then you plan that, okay, I will give this drug and will monitor it like this. For example, a patient is hyponatremia, having hyponatremia, and I'm going to give sodium hypertonic saline. So hypertonic saline, give it like this, monitor it like this, administer like this. So all those things should be documented, and it should be documented either in the form of SOAP or form notes. For a pharmacist, form notes are very good. SOAP notes is very easy to use. So you have to document the patient care plan in the patient document file as well.
Sir, एक और क्वेश्चन के I'm sure they ask in English. So basically, patient care plan is a solely responsibility of a clinical pharmacist, or a hospital pharmacist even can contribute.
Sorry, if you could repeat it again.
Sir, the question was that the patient care plan would be only restricted to have been done by only a clinical pharmacist or a hospital pharmacist, or both.
No, it's a joint responsibility. Usually the patient care plan is usually at the clinical pharmacist, but being a hospital pharmacist does not mean that you're not going to make any kind of clinical interventions, etc. So being a hospital pharmacist, if you find there any kind of discrepancy or any kind of intervention, that should be documented. If there are clinical pharmacists, you could communicate to them. But hospital pharmacist, if you see different type of roles being performed for the clinical pharmacy, you will see a different type of roles are being performed by hospital pharmacists. So documenting intervention is also a part of care plan that is visible to the doctors or nurses, but that is not too much detail. But a detailed care plan is made by the clinical pharmacist. But it is not like restricting a hospital pharmacist that he is not involved in any kind of care plans. This is wrong.
I think, sir,
All
since
right.
the clinical pharmacist is more directly involved during the rounds, for multidisciplinary teams में involved होते हैं, तो वो directly patient care therapy देख रहा होता है. So he is more like front end, or hospital pharmacist then उसको re-verify कर रहे होते हैं.
Okay.
Another thing I think we have missed is the ADRs. The pharmacist is also responsible for highlighting the ADRs as well, which is pharmacist को पता होती है कि अच्छा ये reaction आया तो ये इसका ADR हो सकता है या side effect हो सकता है. सर इसके बारे में अगर आप कुछ explain कर सकें.
In the start, we have talked about the medication safety. So safety is that preventing a patient harm. ADR is kind of patient harm a patient could experience. So being a medication expert, we know what kind of medications we are going to use, or what could be the what could be the issues a patient could face. So being a pharmacist, it's your responsibility to report any kind of ADR. So ADRs is very important. You have to categorize those ADRs, and you have to identify those preventable ADRs as well. In a study, it was found that around 5% of the hospital admissions, like 1 in 20 patient in a hospital, is admitted due to the ADRs. So reporting an ADR is very important, and preventing the ADR is the role of the pharmacist. We have to identify that this is an area that could be prevented. For example, a patient is suffering from the nephrotoxicity due to the acyclovir, that could be prevented. So a patient is having any kind of reaction, allergic reactions, that could be prevented with the use of any kind of hydrocortisone, etc. So there are multiple type of preventable ADRs we have to identify, and pharmacy should involve in it and should perform his assessment.
I think that's a lot from our end. I think we should involve our audience now as well. They have a couple of questions also. There was a very interesting question that said कि हमारा course 3 years का ही होना चाहिए. Why is there a need to have 5-year degree? क्या कहेंगे इस बारे में?
It's a wish that our course should be of 3 years. Might be the person who asked this question is too much efficient. He could go through all these things and could learn
Complete
it.
it in 3 years.
Internationally, if you see that in India, Philippines, they have formed a curriculum of the 6 years. Okay,
Right,
and
that's
thing
right.
is, and the thing is that they have incorporated the practice in it. And I see, sorry, I see there was a question that that was asking that we have so much theory and we don't have any experience there. This is the point that theory should be there, and with that clinical application should be there. So if somebody is going to reduce it to 3 years, and if it is doable, if you think so, so I have no objection. You can go it for 3 years. But for me, it should be at least according to the international standards, like where practice is, pharmacy practice is there, and they should be given a chance to apply those learnings.
Sir, there is another question कि एक hospital setting में अगर data ही systematic नहीं है, it's manual. So how will you effectively do DUR, DUE, and how will you document everything?
The thing is that if there is not an EMR or online system or management information system, that that does not mean that we are not going to conduct DUR or DUE, because yes, that might be a hectic process, that might be some tiresome process. You have to go it. In that case, I would recommend that it would be hard to conduct DUR, and in DUR you are not going to conduct DUR for every patient. You are going to you would have a sample size. For example, you would pick like, okay, I'm going to conduct DU or a DUE for 20 patients or 30 patients or for this drug, for that drug. So it could be a sample based. So that could be very helpful for you if you don't have any online data provision services.
Another question says that how can we increase our approach to patients on international standards during our 5 years of degree?
Or we can
increase our approach according to the international standards on patient care while doing the degree.
Okay. Actually, the thing is, I just was seeing the participant list, and I can see that there were multiple observers. So, observers are those people who are in the currently studying period. So, during the study period, you must know that different type of, for example, this is the session you are going to take. If you are a student, nobody is going to stop you that this is a session you have to take. Moreover, in these sessions or with the professional networking, you come to know that different type of certifications, different type of policies, guidelines, different type of resources. So try to follow those people who are already in the field doing their job. Ask them for the mentorship, ask for them any kind of references they are going to provide you. So in that case, you could come to know that, okay, this is something interesting. And moreover, I would say that please do those things which attracts you. For example, if you're going to, if you are, for example, I like to work in critical care. So I would be more interested in critical care. I would search for things or session for the critical care or the oncology or whatsoever. So try to search that, ask your teachers, ask the mentors, ask the seniors. I would recommend you to use LinkedIn to search for the people in this occupation, in this field, and ask their guidance time to time.
So, sir, basically the networking is really important to get into all those things.
Yes, it's very important.
Communication too, sir.
Yes, communication too, and sometimes by the seniors as well. Please have some
Exactly.
time to guide the youngsters about those things.
Exactly,
Please talk
sir.
about the patient in ICU. Please talk about the patient in ICU. That is Abu Bakr Siddiq. He asked this question. So if there is a specific patient in the ICU, and I can talk about it. But for the ICU patients, there are different type of things you have to consider. The ICU patient is the most critical patient. In that case, your chief complaint is to the save life. So there might be a primary complaint, there might be a secondary complaint. For example, in that case, you are not going to target that, okay, this patient would have HbA1c of 6 while in the ICUs. So a patient with a shock or etc. So in that case, your approach would be different. So you would target things differently. For example, your HbA1c target or blood glucose level would be about 180. So based upon the patient, there are different parameters you have to conduct it. So I can't say too much about it, but the patient in the ICU requires special care, and you have to look for those changes, and frequent monitoring and changes in plan should be there.
Sir, I think this would be the last question for today. It says that can AI assist in predicting potential ADRs or drug interactions during the review process?
AI. I think so. I have wasted one hour here, because if AI is there, the simple thing is AI is a very wonderful thing. We should use that, but we should not blind trust those things. It is like if I asked a question from you, Huba, question from Huba as well, that I am using AI, you are using AI. AI is very helpful in a different kind of prediction. But how would you like it that if I recommend a drug to you using AI?
Absolutely not, sir. It's for getting the feedback onto it, sir. इस तरह से नहीं है कि आप जो है मतलब you're not getting that thing up to the point, up to the mark, but you can get an idea of that thing. But you cannot directly or appropriately approach towards it, sir.
Yes, sir, because there are so many factors. There are so many humanistic factors out there, which AI couldn't cover, and you could not make a proper decisions. Just the person who is going to ask this question in your AI question, just write 2 + 2 is equal to what? That will surely say 4. Say, no, I think it is 5. It will say again, yes, I am wrong, it is 5. Okay, so AI is not yet so much accurate. So we have to work on it, and I think so. It is not a humanistic approach, or it is not an ethical approach to deal any patient with AI. But AI could help you, yes, to have some kind of paths. But ultimately, it should be your decision.
Yes, sir. I would add something that there are other tools as well that can let you that can give you actually the content that can get humanized later. But this was also not correct, and this cannot be you can rely on for your research or other things. Recently, I've read a post on LinkedIn that was about the scholarships. People are getting scholarships from the AI, but they are not completely dependent on that AI. Just getting the idea, just putting all the information and just correcting all those things, organizing and aligning their ideas with the ideas of the AI tools, and just grab the scholarships. They are not like this. If you write ChatGPT or other AI tools that I want a scholarship and I want this statement of purpose, and you can copy and paste this statement of purpose to that professor or to that university. You cannot get that. So you can get the idea, but you cannot get that appropriately the whole content. You have to edit it.
Yes, you're right.
I think that there needs to be a concept of segregation कि AI क्या चीज है और जो tools हम utilize कर रहे हैं वो क्या चीज है. When it comes to calculators, when it comes to using references, that is something else. And artificial intelligence here that you're totally relying on whatever the Google search tells you. क्योंकि
Exactly.
AI after all वही जो इंटरनेट पे है उसी इंफॉर्मेशन को evaluate करके आपको एक आंसर जनरेट करके दे रहा है. So there needs to be this segregation के tools क्या हैं जो एक pharmacist utilize कर रहा है और AI क्या है.
Exactly. They are encoded from the past information, so you cannot rely completely on that.
Exactly.
I hope enough
I
of
think
questions.
that's pretty much it. I enjoyed thoroughly. I think my panelists and my audience will say the same. What about you, sir? It was your first pod talk?
It was my first pod talk ever. So I was a little bit confused at how it will went. So, but it went well.
Sir, welcome to
I
the
think it was
PODTALK
your first experience in
other
world.
PODTALks as well.
I hope so that audience would have learned something. And if there are
Yes.
any kind of help you require, you could reach to us on LinkedIn. So if you message me on LinkedIn, I will surely reply you. I will not guarantee that I will reply you on on WhatsApp or etc. If someone is asking what my intro, Neha, if you could give my intro again.
Please,
My name is Rehan
LinkedIn
Anjum,
करें,
and
सारा intro मिलेगा आपको.
no, my name is Rehan Anjum, and I am working as a head of clinical pharmacy at Shifa International Hospital, Islamabad. So you could search me on LinkedIn by Rehan Anjum.
Yes, you can
You'll be
scroll
amazed to see the introduction.
on our PharMentorZ LinkedIn page, and you can always email your queries that will be commemorated to sir as well. So the email
In a
would
short
be CDU at the
introduction, we are Sir's residents, so you'll get to know who he is.
Thank you so much, sir, for honoring us in this PODTALK. We have been
Let me-
enlightened with knowledge and skills, sir. Thank you so much.
Thank you so much. So I'm leaving now.
Like
Thank you, everybody. Allah Hafiz and best of luck to you.
Thank you so much, Arvind. Thank you. Thank you, everyone, for joining us. Thank you, my dear panelists, for being a part of this conversation. And I hope that our audience gained something out of this, which is always our objective. And thanks for tuning into our PODTALK. And until then, stay curious and keep the conversation going. Take care. Good night. God bless. Okay, about the certificates, yes. Those who have entered in the feedback link in the form, they will be awarded with the certificates in a matter of 7 days. We will also send in an email through which you can also put in your feedback forms. And if there is any query, you can always reach out to us through our email, that is pharmentorz.edu@gmail.com. Thank you so much. Yeah.